Yes.
Thank you very much for giving me such a honorable opportunity, and I appreciate for the moderators. Thank you very much. So my topic is lateral epicondylitis, the pain mechanism of the left recalcitrant tennis elbow, consideration from the surgery under local anesthesia. So there is no cigarette. So etiology of the lateral epicondylitis is 1 to 3% of the adults was recurred, and the most common in the 30s to the 50s, and no gender difference. And 80% of patients improved within the 6 months, and 90% within a year. But the proportion of the leading to the surgery is 3 to 10%. So treatment for recalcitrant lateral epicondylitis is standard ways of debridement or release. So anatomical restoration is not common. So what is the pathogenesis of the recalcitrant lateral epicondylitis? The factor of the recalcitrant tennis elbow in the extra-articular region, incomplete remodeling is measured, and nerve ingrowth in the tendons and the expression of the cytokine of other pain-related substances also related. And intra-articular region, that's the nowhere has presented, that's plica and brachioradial joint disorders. However, it is still unclear where and how patients feel pain. So I performed the tenodesis with the bone marrow bending under local anesthesia since 2015. So this is a drilling and insertion of the ECLB, and just distal and insert the 2 anchors and just not tying. So our concept is the primary fixation is a subcutaneous tennis elbow band by the anchor strings, and the remodeling was induced by the bone marrow bending. So the case is a 50th female pianist. She felt pain in the lateral side of her elbow 4 years ago, and he injected totally the 515 injection of the steroid. And this is video. She cannot extend full read and restrict and he feel pain. And so palpation is also she failed. So I like this. And at first, after local anesthesia, I opened it and checked it, the needle and the painful area. And then the painful area is very located. And after that, adds the anesthesia again and drilling around the painful area, 3 to 6 points. After that, so nearly the lateral side of the capitulum, so I inserted the 2 anchors. And just tied manual marks. And this is the local anesthesia, so patient can move the extension, and the elbow is the flexion and extension during the surgery. And she works for as a pianist again after the 3 months, and now 60 months after that, and 2 years after the session, she can keep her performance. And so this is a change of the MR findings. The severe damaged extensor was becoming at first, the 3 months later, it looks mild. Then after the 6 months, a little bit high intensity was again, but there is no pain, and there is no change in the quick dash and the maps. So consideration from the findings around the local anesthesia, the surgery under local anesthesia let us identify the painful points, and the postoperative results suggest the intra-articular region because our procedure never touched the intra-articular region. So purpose of this study is to consider the pain mechanism of the recalcitrant tennis elbow from the intraoperative findings and the clinical result of our procedures. So patient is a 39 patients, and so the mean follow-up is 36.5 months. And the assessment point is the painful point. This is the intraoperative findings, and the clinical one is this, and the clinical score and the MR findings. So painful point was we decided to fall in the tendon surface, intertendon, and the bone tendon junction and the lateral head. And the MR findings are assessed by the Walton classifications. And the result, that the most painful area is the bone tendon junction. Every patient feels painful and at the bone. And it's very localized. And change of the clinical findings, after the 1 month, the significantly decreased the clinical findings and Thomson test positive at post-operative 1 year, discomfort levels, it's only the discomfort. And all intra-articular region, so it's shown by the fringe impingement test that we can achieve without intra-articular approach. And change of the clinical score is post-operative 1 month significantly improved in the MAPS, and the quick dash is post-operative 3 months after surgery, we can significantly improved. And the MR findings, there are 31 severe including signals was becoming the only one, and 35 can achieve the non or mild changes. So this question. So efficacy of the tendon attachment repair by the bone marrow bending. In the rotator cuff tear, we often use it bone marrow bending. So enter the tendon through the drilling side and facilitate in the repair of the tendon attachment. So bone marrow bending under tendon fixation is effective for repair in tendon elbow. And my main cause of the recalcitrant tendon elbow is mostly the ECRB insertion. And the positive rate of the Thomson test is nearly the 100%. So, and our findings, and the most painful area is the bone tendon junction, especially the bone, and it's very localized. And how about the interarticular region? So 58% of the recalcitrant tendon elbow was found in the interarticular region, but precare can be the cause of the recalcitrant tendon elbow. But fringe impingement test and pain during the elbow extension with the pronation or spination suggesting the intra-articular region. But it's all fringe impingement can be negative by our procedures. And because the structure of the extensor is the superficial layer is ECRB, EDC, ECU, but deeper layer is spinator and the capsule and the annual ligament. And large intra-articular tears or the LCL complication is a pro factor for the conservative treatment. So the degeneration of the tendon may cause instability of the synovial fold, leading to the pain. And the ratio of the lateral support by the bone and soft tissue for elbow bulk stress, compared to the LCL, the capsule plays more important role in the instability of the elbow. And our procedure is tendon insertion is compressed concomitant with the capsule. Thus, lateral side complex is stabilized. Therefore, every intra-articular region is improved without intra-joint approach. So, our consideration of the pathogenesis of the recalcitrant tendon elbow is the pain mechanism is that tendon insertion, especially bone, causes pain in the motion. And the intra-articular region was instability of the synovial fold associated with the degeneration of the tendon attachment trigger pain. And why is the tendon release effective? The nitrile procedure or the Boyd procedure, the tendon is separated from the bone so that pain is not perceived. And in the nitrile procedure, the drilling or not is not related to the clinical result because it was already separated. And the arthroscopic debridement, it was cut intra-articular region and extensor insertion. So resection, but the resection of the fringe and the tendon release by arthroscopy needs a very skillful technique. So skillful doctor can achieve the good result, but it's a little bit difficult. So because the anatomy of the lateral side of the elbow is from articular side is a capsule, spinator, and ECRB. It's very far from the ECRB. So our procedure is drilling at the insertion of the extensor and stabilize the uncast rings. So to facilitate the remodeling of the tendon insertion by the BMB and the destruction of the painful areas, and to stabilize the tendon insertion during healing by the tenodesis, and to stabilize lateral complex of the extensor and the capsule. So take-home message is that this is the pain mechanism of the recalcitrant tennis elbow from the intraoperative findings and clinical results of procedures. The most painful area of the recalcitrant tennis elbow is the bone tendon junction, especially bone. The cause of the intra-articular region may be the instability of the lateral tendon insertion complex induced by the degeneration. So our simple procedure can be a good selection for both patients and doctors. Thank you for your